Next on primary care, lung cancer. It's the leading cause of cancer-related death in black men and women, regardless of their education, income, or occupation.
Black Americans are less likely to be referred for screening. Once they're referred for screening, they're less likely to actually be able to make it to get screened, and they ultimately get less screening CT scans.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health of African Americans. Lung cancer is a serious concern in the black community. Over the years, it has taken the lives of some legendary figures: Duke Ellington, Jesse Owens, Nat King Cole, Donna Summer, and most recently, Andre Barger. For more than 40 years, deaths from lung cancer have been declining among African Americans, which is good news. But what's not so good is that compared to other groups, black Americans have higher rates of lung cancer, get lung cancer at a younger age, are diagnosed later when the disease is advanced, and more often still smoking when they are diagnosed. They also have the highest death rate, even though they smoke fewer cigarettes per day. Here to help us understand more about these disparities and about lung cancer in general is cardiothoracic surgeon Dr. Ikenna Okereke. Dr. Okereke is the Vice Chairman of the Department of Surgery and the Division Chief of Thoracic Surgery at Henry Ford Health System. Dr. Ike, welcome to the show. So glad to have you.
Thank you, sir.
Good, good. Lung cancer. By the time we hear about it in our community, it's a disease that's well advanced along the way. Just from a definition standpoint of view, what is lung cancer?
So lung cancer is cancer that originates in any parts of the lung, and you're correct. I think people are unaware about the prevalence of it. Lung cancer in this country kills more people than prostate cancer, breast cancer, and colon cancer combined.
But we focus on all those others. I mean, even though lung cancer does get a little play in the public, or some play in the public, we hear more about breast and lung than or colon than anything.
Absolutely. So there's a lack of awareness of the modifiable risk factors, and then also things that we can do like lung cancer screening to help prevent disease and save people's lives.
Exactly. So who gets this disease?
So although everyone in the community gets it, what you mentioned at the beginning was absolutely true, that black Americans tend to have more advanced diagnoses at the time of diagnoses, and then also higher mortality. And then also, if you look stage for stage at disparities, stage for stage, black Americans tend to get less definitive treatment, so less surgery for surgical disease than non-minorities.
So if we look at it just from a global standpoint of view, are there any risk factors that we really should be aware of that can predispose people to lung cancer?
Yeah, that's a fantastic question. Our research team is studying it. Without a doubt, the number 1, 2, 3, 4, 5 risk factors are smoking. But then when you look after that, there are environmental pollutants, occupational exposures, and even in Wayne County, and this is a study we're doing, we see that there's significant disparities in air pollution. I think anyone who walks outside sees it. And we see that where black Americans live tend to have worse amounts of air pollution, and there probably is correlation. That's probably part of the reasons why black Americans are more likely to get lung cancer.
We're in a stage and an age now where smoking marijuana or using marijuana is commonplace. What's the role there?
Yeah, I think the answer is we don't know, as we see it on widespread basis, and now it's legal to do. Mm-hmm. And people may be doing it more at a young age and more frequently and maybe for longer, for decades and decades. We'll have to see what the risk is. I think without a doubt, the standard traditional cigarettes are probably the most dangerous, I would say, but we'll have to look at some of the other risks with marijuana.
As a pulmonologist, some of the worst cases I have seen, and thank God it's not a lot of cases, but some of the worst cases I've seen in younger people below the age of 35 or 30 or so, and basically just destroyed lung function, has been with vaping. Is that playing a role in lung cancer?
Yeah, I think vaping does, because if you looked at the early stages when some of the e-cigarettes and vaping came out, the people who vaped actually had a higher nicotine intake because they vaped and they smoked traditional cigarettes as well. And then about 5 or 6 years ago, there was an epidemic of vaping-related catastrophic lung disease. I had a patient in their 30s die a few years ago of that. Yeah, exactly. Yeah.
So how do we make this diagnosis?
So most of the time, unfortunately, the diagnosis is made once a patient's symptomatic. pain in their chest because the tumor is eroded into the ribs, coughing up blood, headache because they have metastatic disease to the brain, and by then it's too late. So the ideal situation is to diagnose it before it's symptomatic with lung cancer screening, just like mammography, colonoscopy, or FitGuard and other testing. Lung cancer screening saves lives.
Cervical cancer, which
Exactly,
for
Pap smear,
years.
exactly, yes.
Okay. So basically, there are some things that we need to be doing that needs to be part and parcel of what we do in terms of taking care of patients, or routines that we should have that actually should get us to the point where we can diagnose earlier instead of later.
Yeah, without a doubt, the easiest thing we can do, and it's a very low risk procedure, no risk procedure, is CT scan for lung cancer screening. We know that right now the current guidelines are ages 50 to 80 with a 20-pack year history. If we screened everyone, we could probably save 30, 50,000 lives a year in this country.
That many?
Yeah.
So, and thank God again, the low dose CT is now in vogue and getting better, becoming more popular. Are we seeing the primary care end of the delivery system participating in this like we should?
Well, I think it's on both ends the problem. I think there's probably more that can be done from the caregiver side to extend lung cancer screening to the community, and then more awareness in the community and lack of mistrust and willingness. We did a study, in fact, and we surveyed about 300 people in the community, and what we found is after a short educational module that there were no racial disparities in lung cancer screening, and people were more willing to get lung cancer screening once they knew the risks than the benefits of it.
So how recent was this study?
Just recently, just within the last few months.
Good. Is it published yet?
One aspect of it is published.
Okay,
yeah.
very good. I would look forward to seeing that because that becomes important. We can, we've got to pay attention to disparities, but we also should be getting the word out when there are not disparities so we know where to focus. That's very interesting. What about treatment?
So and that's one of the reasons, it's all related. Once you are able to diagnose lung cancer, if you can diagnose it early, and people who go through lung cancer screening, one of the reasons that they are saved and that they are able to is that they are diagnosed at an earlier stage, then they're more likely to be able to get curative treatment like surgery. So as a surgeon, most of the lung cancer surgery I do is minimally invasive. So especially for early stage lung cancer, instead of making a big incision, we can do small little ports. I can do robotic or thoracoscopic surgery. Patients go home earlier, have a better chance of less complications.
Some of the same day, isn't it?
Not necessarily. Maybe someday.
But the insurance companies love to hear that.
Yeah, they would love that.
Right,
Yeah,
right.
sure. Yeah.
So who should we be focusing on when it comes to screening? We know smokers, but in addition to that, what about other people in the community that we should be focusing on?
So as of now, the guidelines are ages 50 to 80 with a 20-pack year history. That is an extension of the way things were 10, 15 years ago. So to your point, and what I hope our research team can find is that you may have a minimal smoke history, but if you live in a certain area, or if you reside in a certain area, or you're in some occupation which has a higher risk, that perhaps you should be included in that cohort. And I'll say another thing as well is that if you look at the current guidelines, ages 50 to 80, 20-pack year history, it will catch more lung cancers in white Americans than black Americans, because black Americans have different risk factors and have different epigenetics. And so to your point, one of the things we need to do is find maybe more of a personalized scale, because we're missing a lot of lung cancers in the community statistically that we would see with these current guidelines. These current guidelines in a one-size-fits-all probably won't work adequately in everybody.
Very interesting. Does location play a role in trying to gather this data? The reason I ask is because in this community, over the years, we've had to deal with who's running an incinerator and other effects including the pediatric population. Southwest Detroit, we've done studies there that are this tremendous difference in variation and a disparity simply because of where you live and where the concentration of the population is. Is that being looked at also?
So our team is doing exactly that. We looked at the last 33 years, or a 33-year period in Wayne County of lung cancer incidents, and there were strong clusters in specific areas, meaning you are more likely to get lung cancer in Wayne County over a 33-year period if you lived in certain specific zip codes and census tracts across Wayne County. Now that being said, what we need to find out, is it related to living next to an incinerator, or is it that people who live in a certain area are more likely to have an increased smoking history and be active smokers, and et cetera. So the answer is it's probably related to both. Living next to an incinerator probably does give you increased risk of getting lung cancer, but then we have to find out the other social determinants and modifiable behaviors related to that.
Yep. Boy, that wouldn't be good news for the real estate company or the educational system, which can't pick up the elementary school and move it because of these kind of factors. But
Yeah, it might drop some housing values. Right?
Of course, but here again, it's important that we know this data. The numbers tell us the story, and unless these numbers are shared and exposed, we won't be able to make good decisions about a lot of things that affect us.
And that's exactly it. Once we have the data and once we can determine these correlations, we can affect policy, we can affect personalized medicine to what we discussed earlier. If we know you live in a certain area and you're at increased risk, perhaps you should start getting screened at age 40, 45.
Exactly.
This whole one size fits all is probably not going to be, hopefully, the way things are 10 years from now,
Right.
20 years from now.
Right, just like you tailor the chemotherapy
Absolutely.
to fit the patient.
Absolutely.
We need to be tailoring the social determinants, or at least
Exactly.
looking at them the same way.
Exactly.
Very interesting factors. I know the schools of public health need this kind of support and this kind of help. The health departments do. Wayne County and City of Detroit Health Department certainly could benefit from this kind of discussion in terms of where we're going in the future, especially when we're spending public dollars.
Exactly, yeah. And if you look at the amount of money and the amount of lives lost for lung cancer in general in this state and this country, then absolutely it's reasonable. So I hope that we can get the data. If we have the data, then hopefully we can act on it in the ways we discussed.
How long have you been interested in this kind of research approach?
I think really all my career, and then growing up in Detroit, it really does hit home to me because you see the disparities. As you mentioned, you see Black Americans who just don't do as well. And I've seen it throughout my career, and if I can have some small ability to affect that, it is deeply meaningful to me.
A Pershing High School doughboy. Huh?
Exactly.
How about that? Dr. Ike, tell us a little bit more about the staging of lung cancer. Everybody doesn't show up late. Screening has helped us diagnose people earlier. There are stages from beginning to end. Tell us more about the stages along the way.
So the basic stages go from stage 1 to stage 4. Stage 1 is an early tumor, small, localized within the lung, has not spread anywhere. Stage 2, there are some lymph nodes involved. Stage 3, more distant lymph nodes involved. And stage 4 is where it has spread throughout the body, to the brain, to other parts of the lung or abdomen. Now, in the state of Michigan, in the last 40 years, 21%, I think, is the number of lung cancers are diagnosed at stage 1 or stage 2, meaning that almost 80% are diagnosed at very advanced stages. And even though things are a little better now, in essence, early lung cancer is curable, advanced lung cancer is highly incurable. And so the more we can diagnose it at stages, especially stage 1, stage 2, the better patients will be.
21%?
Roughly 21%.
So hopefully screening will improve on that percentage.
And one of the things you see in all screening trials, it's at Henry Ford, the National Lung Screening Trial, which was a nationwide multi-institutional. Patients who are enrolled in screening trials tend to have a higher rate of diagnosis, higher percentage of stage 1, stage 2 diagnoses.
Is there a disparity within that number? Are we looking at a percentage rate that would be different for the African American population, especially Black men, since they get this disease more than anybody else, or are we pretty comparable?
Yeah, unfortunately, probably the primary problem is that Black Americans are less likely to be screened. In this community, we have a little better. We have a little better in terms of disparities, but nationwide, Black Americans are less likely to be referred for screening. Once they're referred for screening, they're less likely to actually be able to make it to get screened, and they ultimately get less screening CT scans percentage per capita than white Americans.
Are we seeing a distrust to the degree that it would explain a lot of that disparity? Are we seeing a fear? You know, years ago we had patients that were afraid of needles to a great degree. Now that fear has pretty much gone away.
And that's another great question. I think that we look at what are the reasons why people do not get the same level of care, whether it's lung cancer treatment or others. And I think one of them is medical mistrust. I try to tell some of my younger residents and trainees the Tuskegee syphilis trials were less than 50 years ago. There are people who are still alive who either were part of it or had family members who were involved in it. So it's not as if this was 200 years ago. There's significant medical mistrust, but then there are also social determinants. Let's say that your PCP refers you for a screening CT scan, but it's Tuesday at 3 p.m. and you can't make it. 20 or 10 miles up the road to get the CT scan because there's no CT scanner or no institution in your area. You can't get off of work. You don't have the resources to make it to the facility. So I think, unfortunately, the access is decreased in many of our communities, and that leads to problems as well.
Follow-up is a real issue for us in terms of the whole screening situation, especially if you can't provide the service in a timely manner, if you've got to schedule somebody 3 weeks out. I mean, those things seem to get lost. The paperwork is,
Yeah.
on
And that's another thing that we are studying, and we're looking at what is the rate of fall off.
Exactly.
Because we recommend screening CT once a year, and we see that Black Americans tend to get screened less likely at that initial, and then also during the follow-up, they tend to drop off more.
We've proven that screening works.
Absolutely.
In this industry. I mean, we did it with uterine cancer, cervical cancer, breast cancer seems to be the most recent one. Colon cancer catching up very fast in terms of people screening. How the new approaches, colonoscopy versus Cologuard, those kinds of things, including cost as a factor, regular CT versus low-dose CT. All of these things should be highlighted and pushed to the community as a whole in terms of improving the percentages.
Absolutely. I think that's one incontrovertible fact. If you find the right cohort, the right guidelines, screening saves lives.
So why is the death rate among Black men higher in this country?
I think part of it has to do with lack of access, lack of referral, lack of definitive treatment at each stage. And then also there are probably some epigenetic factors that the actual tumor biology may be worse based on racial disparities, perhaps. But I think it's a constellation of factors, I would say.
How are we doing with cost on low-dose CAT scan?
So the actual CT scan itself, the cost is minimal. And so I think if you look at the cost benefit, without a doubt, this might be one of the most, if not the most effective screening modality that we have of any solid organ tumor.
The role of the primary care physician in this disease. Of course, they're kind of trying to conduct the orchestra, so to speak, but at the same time, they play a particular role in any disease state, especially as we interact with specialists such as yourself. What role in terms of treatment of lung cancer does the primary care physician play?
Well, I think they're highly important because I think many patients have a special bond with their primary care physician, and they're the first person that they will see. It's very unlikely that a patient will see me first versus seeing their primary care physician or pulmonologist. So I think they're highly important because they're the ones who have access. Now, of course, they're stretched very thin and they have to treat the patient across all conditions. But if we can include lung cancer screening and make sure that we refer every patient between 50 and 80 with a 20-pack year history.
So let's connect it to the primary care physician's role, the specialist role. Do you see any real barriers there?
No, I don't think so. I think there's time. We're all very busy, of course, and unfortunately communication can be strained, but that's probably not a valid excuse, I would say.
Isn't it amazing? I mean, we exist in this society where we have information overload, and sorting through it becomes a real factor. I mean, 200 emails a day,
Absolutely.
Still get a stack of stale mail,
Yeah.
Got to see patients, got to communicate, got to make phone calls. How do you handle all of those things to the degree that you consider that you did a good job today?
I think when I get there, I'll let you know. But I think in the meantime, you just try your best.
Right.
You try to be as organized as possible, and you understand that I tell my young trainees, if you have the mentality the patient comes first, you'll find a way to do it.
Yeah. Speaking of trainees, where are we in terms of African American trainees in the subspecialty of oncology, in the pipeline? Where are we in terms of people getting into fellowship programs and winding up in communities that need them?
Well, unfortunately, we're not at a great place. It's sobering, the statistics. I can tell you for cardiothoracic surgery, one of the training paradigms that we started about almost 20 years ago now was the I-6 program. Straight from medical school, in 6 years you go through all your surgical training, you become a cardiothoracic surgeon. Only 2.2% of trainees in the I-6 program are African American, and has not shown a significant increase in the last 18 years.
So we've got a lot of work to do.
A lot of work. Yeah. That's an understatement.
Yeah, how about that? I'm going to take the opportunity on the tails of that to let you talk about the mentoring program that you've been conducting for at least 6 or 7 years.
Yeah, 8 years now.
8
So in
years now.
2016, I started a high school mentorship program. I did it for a variety of reasons, but my goal was to try to get the most, what I consider the most vulnerable in our community, or one of the most vulnerable cohorts, which are young African Americans, and try to get them to consider careers in STEM fields and all specific careers as physicians. So we have 3 phases. Phase 1, myself and other colleagues, we go to different schools. We've gone to about 20 different schools now, and we talk about our lives, the discrimination we've faced, what it takes to get from high school to being a career physician. Phase 2, we have a simulation center where we can do simulation, surgical drills, and we actually have a microanatomy lab with a cadaver extremity. High school students come on Saturday mornings. We have about 15 sessions a year that we do. They come on Saturday mornings and do dissection, simulation, surgical drills. And then phase 3, we have an application and select interns. We pay $1,000 and we pair them with a mentor. Someone wants to be a cardiothoracic surgeon, may be paired with me, neurosurgeon, architect, lawyer, media.
Whatever.
Doesn't necessarily have to be in medicine.
Good. And how many students involved in that program now?
It's been thousands now. There have been hundreds of phase 3 interns, and we just did recently looking at the outcomes for phase 2 and phase 3, and the people who responded, 75% of people who have been involved in phase 2 or phase 3 are still on tracks to be physicians.
So you're in the process, or you have data that talks about matriculation to undergraduate school?
Yeah, exactly. Yeah, matriculate to undergrad, to medical school, some in
Okay.
residency from the early years.
So you're making an impact.
Slowly, and I have to stress that it's never one person. So I have dozens of people who work every day. You don't want to talk about hundreds of emails every day. We get phone calls, we get emails, but we do this because we care. And it really has been, I think, one of the highlights of my career, I would say.
Good. You have any medical school graduates yet out of that program? Or getting close?
Getting close.
Getting close.
Yeah.
Good, good. We certainly be interested in following up on that, connecting a lot of the programs that are in existence in this community to start talking about what the similarities are and shared experiences and pathways going forward that, somebody might be doing something much better than you're doing, and you can benefit from that, and that's very important that we share that information.
Yeah, I would say this would actually be a call out that I'm a thoracic surgeon,
Yes.
so please, anyone who knows more about
Right.
high school education and evaluation, please help me, please call me.
Exactly. I just think the exposure is phenomenal. If I had had that kind of exposure coming along, I may have turned out quite differently. But here again, I mean, we have to impress upon the students, the children, and children and their thought processes about this, regardless of their age, how it is certainly possible you can be a Dr. Ike before you can be a LeBron James, and those statistics are there. That's a reality.
And it's very true. I always have this phrase I borrowed from someone: if you can see it, you can be it. I remember growing up, there were some things I was taught to believe that I didn't belong to me. You're not supposed to be this, you're not supposed to be this. And I had strong parents who told me you can do whatever you want, and they didn't mean just as a cliche. And I really tried to spread that out to the kids, that you can be whatever you want. And when these kids go into the surgical simulation suite and they see how good they are, maybe it's because of TikTok or Instagram or Fortnite, whatever it is, they see how good they are, they say, oh, I can do this, this is not that hard.
Right, I think they bring a skill set already to some degree that some of us may or may not have been exposed to.
I think the hand-eye coordination of this next generation is
there.
much better than ours, yes.
Tell us what's coming down the pike in terms of lung cancer. I'm always interested in the next phases, the next treatment, the next stage. I mean, what are we in store for in the future?
Well, I think the future is bright. About roughly 10 years ago, 180,000 people died of lung cancer per year in this country. This year it'll be about 127,000. That's still a lot of people, but if you consider a 33% decrease in mortality or 25% decrease in mortality over the last 10 years, there are new medications, there are new immunotherapy agents, lung cancer screening. Right now, about 6% of people who should get screened for lung cancer do. Imagine if that's 50%.
Right.
And then with increased awareness, increased minimally invasive treatments to make the actual definitive treatment safer, if you put all of that together, I think that in the next 10 years, we'll continue to see this drop in number of deaths per lung cancer in this country.
Lastly, the importance of clinical trials in this overall conversation here. It wouldn't be fair for us not to touch on that, because that is going to be the way of the future. It doesn't make sense for us to do research and not have certain populations represented properly. I mean, I think we got a whole list of drugs that say, they don't work as well in some folks as they do in others. So talk about the clinical trial approach to this.
Yeah, no, absolutely. Clinical trials are what have got us to this stage and what will get us to the future. Just as you're intimating or implying, if you design the cure for cancer, but it's only available to 10% of the population, what have you done? And unfortunately, there are major disparities in clinical trials as well, and that's something that we have worked to overcome. Right now, 5% of clinical trial participants are African American, whereas there are some disease processes that affect African Americans predominantly. And that's why you see some of the problems with the efficacy of treatment, where the efficacy is better in white Americans and not as good in black Americans, because research was done with white Americans. And so hopefully, and one of our goals is to try to increase participation of these clinical trials in African American representation.
Right, very good. We certainly look forward to having that discussion in the future sometime and how well we have done and the accomplishments that have been occurred. Dr. Ike, this has been outstanding. Thank you so much for taking the time out to join us today. It's been certainly a pleasure to not only have this conversation, but to hear about all the great things that you're doing over there at Henry Ford. We really appreciate it.
No, thank you.
Our guest today has been Dr. Ikenna Okereke, Vice Chairman of the Department of Surgery and the Chief of the Division of Thoracic Surgery at the Henry Ford Healthcare System. When lung cancer is found and treated in its earliest stages, it can be cured much of the time, which is why screening is so important. Until next time, I'm Dr. Lonnie Joe. Thank you for watching.